Hi, welcome to Ask the Expert series on specialist weight management. I'm Dr. Rajeshwaran, consultant endocrinologist and bariatric physician at London. So I manage the London Obesity Clinic and I'm also the director for Simplyweight. So as you know that we've been having conflicting opinions and reviews about how someone can lose weight. Sadly, in the last 40 years, there's been an increase in the number of people who are obese, but at the same time, there are millions and millions of new interventions for weight loss, hundreds of diets, medications, and other interventions. So to get everything straight, we have started Ask the Expert series just for weight management. So, the first of our experts is Dr. Ashish Thakur. He's an eminent cardiologist who works globally, mainly in the UK and in India. He works in the NHS and he's got a special interest in interventional cardiology, complex coronary artery disease, refractory angina, complex atrial fibrillation, and also exercise and cardiovascular disease. He's a renowned international speaker and runs a cardiac network remotely to connect deprived areas of Bihar in India. He's an award-winning teacher. He's a recipient of Teaching Excellence Awards and also Clinical Excellence Awards. He has peer-reviewed several publications and textbook chapters. Most importantly, he runs a global charity helping people with heart disease, both in the UK and in India. So let's welcome Dr. Thakur. Hello, Dr. Thakur. Thank you very much for sparing your valuable time. I know you've just finished your clinic, and then I also understand you had teaching of junior doctors. So thank you for coming and sharing your expert advice. As you know, that there are lots and lots of people up and down the world who are going to watch this and going to benefit. And I know you're going to show us the ins and outs, which people must have never seen all these things before. So,
thank you. Let's hope so.
Before I start off, the first question which my patients ask is, Doctor, if I am big, will I have a big heart? What do you think about that?
Well, that's a very, very interesting question, and you see lots of souvenirs all around when you go for traveling here and there. You know, the mugs and lots of things saying "big heart." I've got a big heart. So yes, a big heart is a good one to have, and there's a saying that if you can if you can ignore few things like being criticized, being taken and negativities and all sorts of things, then you really have a big heart.
Yes.
And there's so many books have been written on, you know, who's big-hearted, and oh, you're a big-hearted man, you've got a big heart. But that's one side of things. The other side's a bit more scientific. That why is the heart big? You know, it doesn't need to be big, more than what's necessary. And with time, you know, the heart can get big, different reasons. We used to think that, you know, the heart adapts quite well to what we do in daily life, with exercise, with intense training, athletes, marathon runners, you know, endurance activities. So lots of things can lead to adaptations in the heart, and the heart gets used to them, gets enlarged, gets slightly thicker, and that makes it look bigger on different testing and until recently it was thought that this is all natural, but
Yeah.
now we say it is not natural. Well, it's natural but not normal, and there can be risks. So a big heart, yes, it's good to have one, but sometimes you can be on the other side of the line and run into trouble with it.
No, thank you. That's a nice explanation. No, just coming on to the same thing about the big thing is my patients, I try to motivate them. I tell them, please lose weight, your diabetes will improve, you won't get sleep apnea, and lots of other things. But they come and tell me, look, doctor, I'm big, but I'm very fit.
Sure.
Well, what do you think about that group of people who say, look, I don't want to be told what to do because I'm very fit? And so what do you think as a cardiologist, what is your take on it?
Well, I think they have a point. They have a point. And this comes from the fact that there's a lot of work which has been done around, about what if I'm a bit overweight and fit?
Yeah.
And I'm able to do everything perhaps compared to a person who's not overweight, who's within a normal weight range, as we say, or as per the body mass index, which is a usual screening tool. And that's in the medical world, it's called obesity paradox.
Right.
So if I can show you something, if you allow me to share my screen, then I'll share with you something which might be of interest. Are you able to see what?
Yes, I can see that. Yeah, I'm sure everyone else will also be able to see that.
You can see a nice mug saying it takes a big heart to help shape little minds. So, and that's what I'm referring to, is the obesity paradox. So on the left side, you can see that there are, there's a central circle, which is called obesity paradox, and on the right side are surrounding it are 3 and 3 circles which have lots of things written in them. I think the gist is that it is a recognized factor that people who are reasonably fit, but their weight-wise, they would come into a category of mild obesity or overweight, BMI 30 to 35 or so roughly, which on the right side in the graph, which is like a reverse hockey stick pattern or J-shaped curve, as we say. If you look at the orange line here, it looks pretty similar to the one on the left side.
Yeah.
Can you see that? So, so which means these people are not at high risk. In fact, they might have a bit of a protection from things like heart failure, and that is generally attributed to lots of things like genetic predisposition. There might be they might have less inflammatory response in the body. They may have less other problems going on. They may have more lean body mass, which generally, or muscle mass in general, which compared to a thinner person. So that is the paradox. And I don't think people coming to you and saying, and this is a paper nicely published from Lancet a few years ago, although with time we are recognizing that beyond a certain stage, there's the obesity paradox is no longer valid, and it is more of a problem than a benefit at all. We don't know yet. I think the jury is out over this, but a message for your people from a heart point of view or cardiovascular point of view, for those who ask you a question that, am I okay to carry on? Yes, they can, but they still need to try and bring their weight or the BMI index or whatever you want it getting under control as best as possible. So this is just work in progress, I would say. We will learn more in the coming years. So yeah, lots of factors contributing, but only for a certain number of people within a certain range of weight than the vast majority of obese people. So is that I hope that
no, that was fantastic.
Thank you.
That particular curve which you showed, that's quite interesting.
Yeah.
That means slightly overweight people are protected to some extent.
Yes, just within that small range, and you could see that the graph goes up and up, which means the risk goes on up and up as the BMI goes on up and up.
Yeah. I think so. So I can tell my patients, okay, it's good to be fit, but please try and lose some weight.
Carry on. Yes.
Yeah. Now, still sticking on to that. Now, my patients, obviously, a lot of my patients are very, some are very impulsive, not a lot, some are very impulsive. And they say, look, doctor, I just want to lose a lot of weight because I'm going on a holiday and I need to lose, say, 3 stones or 20 kg in 2 months.
Sure.
I get scared of this, and I tell them, look, I don't know. I mean, you need to consult a cardiologist if you've got an underlying heart problem. So what is your advice on that?
Well, I think the question is valid. The concern is valid to lose the pre-holiday, weight to get in shape for the holiday and then come back and feel that, you don't have to do much. Of course, but that doesn't really come with a lot of safety, because rapid weight loss, we know with time can lead to, from a cardiac or cardiovascular point of view, primarily 2 or 3 things. So first of all, it can have a negative impact on circulation, especially the blood pressure. Our blood vessels might react adversely because of the dramatic or drastic change in what they've been adapted to. And that too happening over a short course of time, combined with all the metabolic changes which happen in the body. Along with that, there are changes which the heart muscle has to adapt to within a very short space of time. So now all this happening to a person who has underlying heart problem or a heart condition, not necessarily wanting to go on a holiday, but just wanting to have as fast weight loss as possible. Well, there's a question about, medical advice, what's safe and unsafe, how fast, etc. And of course, the sustainability factor from that point onwards for their health. But in terms of the healthy obese people with very rapid weight loss, they should not be doing it in principle without proper medical advice, because there can be a quick rebound, as you know, and of course they can have something called heart failure. They can have something called arrhythmia or abnormal heart rhythms of all different types because of changes within the electrolyte systems of the body. So it's a complicated scenario, but in one simple sentence, it should not be undertaken without proper medical advice, guidance, and certainly not completely self-directed.
Oh, thank you very much. That I'm convinced that so I can say for definite that, look, I've got an advice from a cardiologist, so don't take it lightly and don't go for these crash diets.
Of course, that's right. Yeah.
So now I know you look after people with hypertension, cardiomyopathy, which is a big heart problem with the heart muscles, but you also do lots of pacing and interventions, a lot of fancy stuff you do. So what do you think my group of patients will have? What heart problems do you encounter with obese people?
Right. So shall I take you to some few things which might then help things make a bit more easy to understand from that point of view. So if this is seen properly,
I can see it.
So this is from walkingoffpounds.com, which is quite a useful site. So we know that there are lots of cardiovascular risks. So this is a general slide which tells you, what's evolving, and we're learning by the day. Actually, lots of things are adding up to the risk of having your first or beyond cardiac risk. And of course, within all this framework is genetics, family history, and a few other things. And obesity or being overweight simply adds to it. But going specifically to the factor of obesity, I think if you refer to some of the resources from British Heart Foundation, I think, and you'd know it better perhaps, that there's something called the fat, which is within our internal organs, and something which is within our the outside aspects of our body, within below the skin and the subcutaneous fat. And there is a complete difference in how these two fats behave in terms of causing us medium-term, immediate, and long-term risks of different conditions, primarily cardiovascular and other organs. The visceral fat is the one which perhaps causes most of the problem, and is hard to get rid of, and rather than the subcutaneous fat. So that's just a general introduction. And then, if I may be a bit more kind of, this is just a cartoon showing, as in a way, from head to toe, as to what carrying more weight with time may lead to, starting from mental health effects down to the very bottom of recurrent cellulitis, knee and ankle and joint problems. And within all this, we've got so many complex organs, heart and lungs, to name a few. So this just sums up, that in time, what a person may lead to, along with it, is quality of life, and also the ultimate thing, which is loss of life in terms of number of years. So this is just one summary of what impact obesity might have in long term on life, in terms of causing dysfunction to different organs. Specifically, how does it affect the heart? Now, very simplistically saying, it's a demand-supply mismatch. Carrying more weight needs more oxygen, more blood volume circulating in our body. The heart has to work hard, has to work over time, and then it eventually tends to feel weaker, which is known as heart failure. So that's a very, very, very simplistic way to say that, but it's much more complex and much more varied. So if you see what's the ultimate worry of people in terms of if they're overweight, or you're a doctor as an obesity specialist, if you're worried about your patient, you might worry more about them having what's seen here on the left side in the cartoon, the zoomed up version showing an artery clogged up with buildup of cholesterol shown in red, shown in yellow, and that is what we worry about in these people, and that would lead to eventually either angina or a heart attack requiring emergency or urgent treatment. So I wouldn't say that this causes one problem. This is a full-blown syndrome or a constellation of conditions. And in terms of cardiovascular, I would say in top order, top to bottom, without any preference, this causes high blood pressure, high cholesterol, heart muscle disease, heart artery disease, abnormal heart rhythms, and propensity to clotting, and also, not to forget, a heightened risk of inflammation. Our arteries change with time, and that is directly or indirectly linked to the very high risk of diabetes, which comes with obesity. And below are listed some other conditions, but I don't think they're relevant to this particular session. However, I think for the sake of completeness, I think I would say they are relevant as well, because they're linked directly or indirectly into heart disease as well. And we call this as a metabolic syndrome, but I think there are 4 or 5 or 6 conditions which obesity directly links into the heart disease. And then talking about, if you go back to the previous the cartoon showing that visceral fat, this is a visceral fat which triggers lots of reactions in the body with time. It tends to cause imbalance in hormones. It causes um, a altered levels of different hormones which are listed here, different chemicals, which then effectively link into our arteries in the heart and some other vital organs getting narrowed with deposits of unnecessary material and damage, and ultimately, leading to the ultimate event. And the other thing is that the heart is made of different structures. So we have something called the heart muscle. Never to forget, it's a pump which has to contract for life. And you can imagine in a person who's been obese for a number of years, the heart has adapted with time. And this is a nice paper which really put everything together a couple of years ago in terms of how, in different ways, it can eventually cause weakness of the heart muscle and what we call as obesity-related cardiomyopathy, where the heart muscle goes weak and the ability to pump and generate enough blood with enough, which then affects the organ function due to lack of oxygen to those organs. And we call this as heart failure in medical terms, requiring a range of treatments. And this is a big problem currently worldwide. And that's pretty much summarizes everything in one slide, where you have this whole cobweb of obesity. Around all this is the risk of different risks and how it all works: diabetes, hypertension, cholesterol problems, coronary artery disease, abnormal heart rhythms, heart failure. And on around the side in blue, you can see different ways in which things work in terms of either clotting, inflammation, high levels of our what we call as a circulating catecholamines, higher plasma volumes, higher fat infiltration into the tissues, and along with all this, breathing difficulties, breathing patterns. And in general, all this leads to, I wouldn't say that this is one thing in particular. This is just a combination of things which I think people who are watching it may appreciate that how complicated it is, that the lungs are no different than the heart. They get equally affected. COVID-19 has shown that. And of course, it's one big problem. And I would say that this is a much bigger pandemic than anything else as of today, if you agree. So just a couple more things, that this is something which is rather, we know this for some time, but this is just to highlight that we have about a couple of, at least a decade between, I would say, 10 to 20 years of biological age to try and reverse things. If we see the trend, let's say in a child turning into a teenager, turning into an adolescent, and gaining weight and weight and weight, which is unacceptable for their age, then there is a time in which you can intervene and get it right. Otherwise, beyond a certain time and age, it gets difficult. You've lost that window period, and then the person then gradually gets the risk. And as the stresses and strains of life, education, career, profession, and financial needs, etc., and the life crisis, etc., kick in, I think it then gets a one-way process where, what's here called on the right side, you can see this future cardiovascular health that gets ultimately affected, and one ends up having a range of problems due to obesity, which this one summarizes pretty well. And this is pretty old. This is not something which we have known recently. This we know for a good number of years, that there is a timeline to it. And you can see that, you can still be obese and have a pretty healthy looking artery with nothing else going on. But as you enter your third decade of life onwards, I think things start to get problematic if someone is at risk. Now, that risk not necessarily be obesity. It could be a combination of things. But we know obesity causes 4 or 5 key problems, especially in the Asian or that side of the world. They are at a higher risk, at least a decade younger. And you can see that on the rightmost side, there is a worst case scenario, which is a heart attack, where ultimately the buildup of the cholesterol has caused the rupture in the internal lining of the artery, causing a clot, and this is what you want to prevent in the first instance, and that's why interventions are needed around this stage, not to get to this stage in order to prevent this stage. So I think this is just a overview of what how it might lead to, and how the obesity affects the heart in terms of heart muscle, the heart arteries, and also that's just a normal heart artery buildup of the plaque. Well, it's fine at this stage. You might even not notice it, but that's when the person might just come to the emergency and ring the emergency number, and then would need something doing to the heart. And on the right side of the cartoon showing what's happening, a balloon is going into the artery and a stent is being deployed to unblock that artery. So electric wise, the bigger the heart, the more strained and the stretched are the heart electrics.
Yeah.
On the left side, you've got an ECG, which is so-called the normal ECG. On the right side, you can see that these are pretty narrow, pretty thinner looking electrical waves. And on the right side, you can see that these are wider looking waves, and that's very typical of heart muscles which are stretched out. We call this as a bundle branch block. It doesn't mean that there's a heart block or the heart is blocked. It just means that the electricity is conducting slowly, and it's a well-recognized feature in those hearts. Irregular heartbeat is one of the most common complications at certain age and beyond in obese people. And that is a good cartoon to show that you've got these electrical waveforms in very disorganized forms on the right side compared to the left side, which has a smooth waveform. And on the right side, you have got this irregular waveform, which is the commonest heartbeat abnormality in the world, known as atrial fibrillation, one of the main causes of stroke, requiring stroke prevention treatment like warfarin and other medications alongside. And ultimately, you don't want to have this in an obese or morbidly obese person, is a heart attack. So on the left side, the person's having a typical massive heart attack affecting a certain area of the heart. On the right side, it's a similar story in a different area of the heart. So these are two different ECGs showing you two different kinds of heart attack. On the left side, it's called inferior wall myocardial infarction. On the right side, it's called anterior wall myocardial infarction. And these are depending on which areas of the heart, based on ECG, show you that particular amount of change. And when you take them to, when you take these people to the catheter labs, sometimes you would see what's, if you can see it clearly on the left side, either the arteries would look normal. So you can see these flowing tubes with dye going through the catheters. So the black thing is the catheter, and what's going into the arteries, which are the wiggly things, they are looking pretty smooth. That's the left side. And on the right side, you can see there, similarly, the artery on the right side, if you see and trace it all the way down, there are no obvious blockages or obstructions. It's a pretty smooth tube. So that's what could be a normal artery. And that's what is typically seen in most of the obese, diabetic, multi-comorbid patients with narrowings and all sorts of, thinnings and thickenings and beading and all sorts of patterns, as you can see, right from the top till the bottom on the right side, on the left side, which is in medical terms called triple vessel disease. And generally, these people require a bypass surgery. So that's a typical diabetic coronary angiogram procedure, which shows you these changes, and you can't put a stent everywhere because that's technically difficult, not suitable, unsafe, and these patients are best served by a bypass surgery, which protects them better long term. However, if they come to you as an emergency, as you saw in the first ECG, which show you a heart attack. Now, sorry, so let me just go back a bit. So here you might see, so that's the catheter and you can't see anything beyond. So you know that there is something horribly wrong there and you need to act in time. And within a span of 15-20 minutes, this is an unblocked artery. This is the artery which was blocked at this point and has been opened up with a balloon, a wire, and one or two stents have been deployed, and the artery is now fully open. And effectively, this person, not just the life has been saved, but I think the long-term implications, the heart muscle damage would be minimal. The associated risks would be minimal, as minimal as possible. The person would be able to live a life as normal as possible, and should be able to reduce weight if they're obese. I think it's so difficult for these people to have these events and then lose weight, because it has physical, mental, financial, and you name it, one after other effects which kick in, and then it almost becomes impossible for them to change their life. So I think on that note, I think we can carry on discussing.
Yeah.
Thank you.
Well, I don't think it was just an overview. I think it was hugely comprehensive. That was fantastic.
Sure.
So it is not an overview.
Yeah, the last thing I wanted to show you on that note, can you see this? That you talked about a big heart, didn't you?
Yes, yes.
So the big heart, yes, it's nice to have one, but this is not the big heart an obese person may want to have, because on the right side, what you can see is a heart which is wider and bigger than the left side. The heart chambers, as seen on the left side, are smaller, thinner. On the right side, the heart is thicker. The chambers are larger, and these are the chambers which are weaker and which also affect the electrics of the heart, because the upper chambers are bigger as well. And these are the usual changes you expect in any person with time, with obesity. And just to show you how it translates into when we do ultrasound of people called echocardiogram.
So what, from the Dr. Thakur, from the previous slides,
yeah,
I think I've got some take-home messages. What I've learned is you've clearly demonstrated that fat is not an inert organ. It's not just a blob. You clearly showed how important the visceral fat was, how much hormones and chemicals it was producing to cause the heart problem. Then you showed us the timeline. That was fantastic. So what you are trying to warn is that you can't keep waiting till an episode happens.
Sure.
So you clearly said that. That was what was hitting me, was that if someone has a heart attack, and that means they can't go and exercise immediately. If they have heart failure, they're restricted in what they can do, and then because they're restricted, they put on more weight. Then it becomes a vicious cycle.
It's a vicious cycle, and to be fair, I think it's much more. It impacts much more people who are obese or morbidly obese, because you can see here, it's in front of you right now, that on the left side you have a heart which is normal, which is thin in terms of its chambers. The chambers are nicely contracting, and on the right side you've got a heart which looks much wider. So it's quite nicely shown here.
I can see Echocardiogram, yeah.
Yeah. So if you see this particular screen on the left side,
Yeah.
um, the particular image shows you a contracting heart, which is like a nicely contracting pump.
Yeah.
On the right side, what you can see is a thinned heart muscle as a result of a heart attack, and
Yeah.
a much wider, what we call as a enlarged heart, which is much weaker to contract. And that's what affects the lifespan, not just the life quality of life, but it has a major impact on prognosis. And they have to be on medications for life, but there's no guarantee that that's going to give them, you know, the years which they would have otherwise lived. So I think the major impact is on prognosis, quality of life, and everything put to one side. So that's the reason that these people need to be managed very aggressively, focused, bespoke, and with as much precision as possible, in order to prevent all that's happening with them. So I think so that effectively kind of summarizes how the heart can get affected by obesity in different ways. Yeah. Okay.
Well, your advice is basically is please don't wait and intervene sooner the better. Look after your weight. Don't wait till something has happened. Don't go and seek weight loss till something has happened. Do it as soon as possible.
Yeah. So I mean, the NHS and of course most of the health systems have over 40 checks where you get a basic check of everything if it works.
No,
Um,
Dr. Thakur, what happens is,
yeah.
people come to you when they have chest pain or shortness of breath. And the government also realizes that if someone else comes to you with chest pain, the
Sure.
funding is good. But when they come to me, they don't have any problems. They don't listen to me.
Yeah, of course. So on that note, yeah, I think you're absolutely right. I think COVID-19 is a good
Yes,
example of
exactly.
of
It's
of
sad.
how
It's sad, is it, that so many people died?
sure and how it may perhaps change perspectives around the world,
Yeah, yeah,
including, to quote our prime minister from
yeah,
various media reports, that he's so concerned that he thought that this was perhaps responsible for
yeah.
for his intensive care needs, etc. Unquote. However, I would like to share with you something which could um, explain this in a bit more of perspective. And this is a wonderful summary published in Nature Reviews recently within the COVID pandemic times, that why do obese people go on to have such a severe course of illness? And that primarily, I think people need to know this, that it, they have a compromised lung reserve. Their lungs are not acting as best as possible, even at baseline. The muscle strength is lower, especially when they're lying. They might have underlying kidney, cardiovascular, or diabetes, simply diabetes. We know that 40% of people who passed away, unfortunately, were perhaps obese, and about 2/3 going to intensive care had obesity. And from the American perspective, I think 90% or higher, if I'm right, were in a similar category in intensive care. So I might be wrong on exact statistics, but I think
No,
the message
you're
is,
absolutely right. You're absolutely right. It's more than 90% in New York, and
yeah.
in
So
UK, the
and
70%.
and then the third thing you see here is the metabolic risk, because they have this very imbalanced imbalance of metabolic factors, of insulin not acting properly, dyslipidemia, hypertension, prediabetes, and along with all this, they have this higher risk of infection due to reduced immunity. And you won't be surprised if that leads to a person who doesn't have anything else goes on to have COVID-19,
Yeah.
and gets a much more severe illness and requires intensive care and ventilation and all sorts of things. So that is, I think that will change a lot of perspective going forwards, and people, and with the public messages going out about this particular denominator, which we have now learned from one of the largest studies published. The first time it was 16,000 people. Now we have about 20,000 plus patients who have been studied in the UK on its own, with obesity and diabetes as one of the two most important comorbid factors responsible. So that puts, I think, things in a bit more perspective. So
I agree. It's been very scary times. I mean, for a lot of our patients, and as you fantastically explained, why just having an excess weight without having any serious medical problems can make you prone to succumb to this pandemic of coronavirus. And as you know, that just I mean, the people can come up with vaccines, but the
yeah.
problem is there may be another variant of coronavirus. So people have to sort themselves out, or not just bank on these vaccines. They need to wake up. So I think this pandemic was a wake-up call for all of us.
Yes, absolutely. And I think going forwards, the emphasis would have to be twofold. One is, of course, to deal with the current adult obese patients who are especially young and might fall victim to this
Yeah,
silent.
that's what I wanted your advice for people who are obese and who have cardiac problems. What is your advice for them?
Well, I mean, for those who are obese and who have non-cardiac problems, I think they are ideally best served by bespoke advice regarding weight loss, along with in a holistic way, and should feel challenged that they need to do something, because they've been through it. They've had a change which they didn't expect in their life, and that might have long-term consequences for everyone in a different way. Support is available. They can seek all sorts of different support, and as you saw at the beginning, that as you go from head to toe, what if someone has severe joint issues? What if someone has severe levels of obesity on the higher scales, towards the higher side? I don't think they might be able to lose weight that easily. So there has to be that individual care plan for them, which needs to be built in with lots of support individually for them, to try and get them. It's not just about getting on a treadmill. Not everybody can walk on a treadmill.
Yes, that's right.
Or even go for a simple walk. So I think it's that combined with medications. So specialist advice wherever needed, is key to it. And I think a lot of people are missing out on that. They simply think that I can't exercise, I can't do this. I think reviews are not happening frequently. That should happen. The focus is more on medication for secondary prevention, rather than the lifestyle and the risk factors holistically. So that holistic approach is essential for them to have the maximum benefits going forwards long term. And that's my very strong feeling, because we see a lot of people coming to our clinics, and in fact, so some people gain more weight than expected. And there are benefits, we know, from this Miami study, Miami Diet Plan study, which that there are so many benefits in people who have had events, of course, that they can have these all sorts of benefits, which would translate only into reduction in the symptoms, the rates of recurrent events needing hospitalization and other things. So I think the single message is seek advice, and seek specialist advice where needed. Have a plan, and do not hesitate. Do not sit back and think that you just might be able to do it on your own.
No, thank you. What I also learned from your slides on the coronavirus is that for people with obesity, it's not just the number on the weighing scale. There's
Not at all.
it's much more than that. That was what you showed us, that it's lots of other things. And then in this current slide, which you're showing, it clearly shows that there are so many other factors which we need to be conscious of. So not be fixated with the number on the scale.
We need to remember that obesity, I think we try and I think use it quite I would say quite lightly or quite casually.
Yeah.
It's more or less it's it's that ABCD. I'm sure you'll be aware. You know that the adipose mediated
adiposity based chronic disease.
That's right. So it's chronic. It's like anything else. It's like chronic fatigue syndrome, which is now called myalgic something of that sort. So I think that's how things are changing. So it is a chronic disease of one of its worst kind, and is a pandemic. To be really honest. Which we can't get rid of so easily. So it needs a very holistic, bespoke, specialist approach. And there are lots of specialists with so much of experience, knowledge. I don't think they're being utilized, both from a NHS perspective or people's perspective who are not aware of them. So I think there's a great need of awareness about the whole thing going forwards. And people are doing so much of hard work to put these all things up. And I think people are either put off, people are either being deprived, people are either hesitant, people think that they don't feel motivated. And they think it's only exercise. But I think it's far, far, far beyond that. A simple diet plan, we spoke to them, could perhaps sort out a lot of it.
No, I agree. So it should be very personalized to them. But what I was looking at is on the last half an hour was we actually discussed two big pandemics. We discussed the pandemic, the COVID pandemic, and then this is a non-infectious pandemic.
Well, I think the truth is that the virus will stay and linger on. The obesity pandemic will get worse. As predicted, the world will have by 2030 about I think more than I can't give you the exact figure, but maybe one of the worst figures ever imagined in the world. So we just have to keep and watch the space, I think.
Thanks.
So
that was fantastic overview, and I think those who are watching, both healthcare professionals, I mean, as you know, that most healthcare professionals do not have an insight into obesity. The amount of, I'm surprised as a cardiologist, you know so much about metabolic medicine. But I don't think a lot of other cardiologists and other specialists in non-endocrine field will know so much as you know. So
well, I think
we need to educate our colleagues. We need to educate in medical school itself, because there's no proper curriculum in medical school. And then we need to go to the general public.
Yeah, I think that there was a recent article 2 or 3 days ago that this pandemic is going to change the way the whole system works, right from the point of primary school education about health and its benefits, especially from obesity perspective as well. And I only have one message to give to people who are well and who are obese, that do not hesitate. But remember the fact that right now we know that number one factor for health is weight. If you really want to worry about yourself, and if you're young, then we have plenty of evidence. This is a very nice Australian paper which showed that there's so many conditions you can simply help and perhaps reverse and reduce by losing weight. And the greater the weight loss, the more the health benefits. So do not hesitate, seek help, seek specialist help, and you'll get there. I think the key thing is the mindset and holistic approach. And this is a very wonderful thing. I'll end up on this perhaps with this is a British Journal of Primary Care Nursing, which shows This is from that, which shows that how much benefit one can derive by losing weight by just 5 to 10% roughly, losing about 30% of your visceral adipose tissue by diet, physical activity, and medications. And I think this is a good take-home message that, if you just go from bottom onwards to bottom to top onwards, you can see that how much improvement almost every parameter on the right side is improved, ranging from your cholesterol levels to all the other things which we've talked about. And ultimately, your risk of coronary artery or coronary heart disease, which is much, much, much lower in intensity, and everything else goes darker, whereas this one becomes lighter in shade because it gets better. And as you lose more of visceral adipose tissue, as you can see on the top 2 circles on the right side and the left side. So that's the message for people who want to lose weight and who want to lose weight properly. Do it properly, and you'll get there without much hassles. But it's a journey which you have to endure and engage in on regular basis. Be motivated, and yes, there will be ups and downs, but yeah, you have help to hand, you have people to talk to, and if you think that one person's not very useful, not to your, you can always switch your the person or provider you want to use. I think it's something which is very relevant to understand that you should not feel that you're stuck with one support system. So take care and love your heart, because you've got a long way to go, and looking after the weight, of course, is key to that. Thank you, Raj.
Thank you, Dr. Thakur. The last 2 words which you mentioned is stuck to my mind. This is for people with a weight problem. You said you need to have a proper mindset, and the second thing that stuck to my mind was chronic. So
Yeah.
You said that it's a journey, as you rightly pointed out. It's a journey. It is not a quick fix. It's not like a cough or a fever or a chest infection. It's a chronic condition. So even if there is ups and downs, which you rightly pointed out, you should keep going. And that's the key. Yeah.
I mean, I can only tell you something when there were no electronic scales, and many years ago, and I used to go to a gym, and then there was this scramble to try and weigh yourself, and they were not very accurate. And then when these electronic scales came along, I think people had to actually wait and queue up, and even if there was a change of 0.1 on the scale, people used to feel elated, and I think that's kind of mindset which people will have if they lose even 100 grams over 1 or 2 days or 3 days perhaps, and if that shows and reflects. And nowadays you have got such sophisticated technology. That's the thing, about both diabetes and weight. And I forgot to say one more thing about the people who are obese and diabetics, that they need to check their sugars frequently. They need to, I think the key thing is about that variation in the glucose levels on a daily basis. And specialists would know more, but I think that's one factor which perhaps could affect their prognosis more if that varies too much. So my apologies if I missed that.
No. Thank you very much. I didn't expect so much information coming from a cardiologist. So you covered.
I think we all learned the time. I think in my about close to 25 years of practice, I think right from my training days, I think I've learned that the more I'm doing these days, I'm more doing holistic work than just core cardiology, because people have so many more needs. You can't just address one thing and leave the other.
Yeah. So you're going to move into the preventive aspect.
Yes, and diabetes is something which perhaps is key to it. I think we have to keep up to date with most recent things, and we find diabetes as a common denominator in cardiac disease. Not to just say obesity, they're all overlinked.
Yeah.
And that's what perhaps our good colleagues who help us with, I'm grateful to them for their kind support with everything.
Thank you very much, Dr. Thakur.
Thank you.
We are going to get lots of questions. So is it okay if we direct those questions to you?
Absolutely, no problem. Anytime, I'll be more than happy to address any questions which come along the way. And,
thanks a lot. Thank you very much. Have a good day.
You too. Thank you very much. Thanks for having me.